Alaikum wa rahmatullahi wa barakatuh. Today we will present a new subject on pediatric surgery made easy. It's an important subject for all pediatric surgeon and pediatrician. Let's start. Today we will speak about the pancreatic disorders affecting infants and children. It's an of ultimate importance, as some of these disorders may be congenital or acquired, and some of these disorders may affect the life of the infant or a child related to the congenital hyperinsulinism with severe hypoglycemia. So let's go. Our objectives today is to study the congenital anomalies of the pancreas, the inflammatory conditions, we mean acute pancreatitis, and what's the difference between acute pancreatitis in a child and an adult. Also, we will speak about the functional disorders with ultimate importance to the congenital hyperinsulinism and how to diagnose, how to treat. And finally, we'll speak about the pancreatic tumors and cysts affecting children. Now, pancreatic disorders in children can be congenital or acquired and may affect the exocrine pancreas or the endocrine pancreas. As all of us know that exocrine, we mean the acinar and the duct. Acini and duct form the exocrine component of the pancreas. Endocrine, we mean the islets of Langerhans, which produce their hormones directly into the blood. To summarize and review, the pancreatic secretions may be exocrine or endocrine. The exocrine may be from the acini and the acinar cells and maybe from the duct cells. The acini will produce the digestive enzymes responsible for the digestion of the protein, carbohydrate, and lipids. The most important is that the enzymes are secreted inside the acini in an inactive form, so they will not digest or injure the parenchyma or the cells of the pancreas. The duct cells is responsible for the productions of large amount of the sodium bicarbonate and water to neutralize the acidity of the acid chyme in the small intestine. On the other hand, endocrine component responsible for the productions of the hormone like insulin, glucagon, somatostatin. Now, what are the pancreatic disorders affecting infants and children? We can categorize these disorders into 4 major items, whether congenital anomalies, inflammatory conditions, functional disorders, or pancreatic tumors and cysts. When we start to speak about the congenital anomalies, it is important to be remembered that the pancreas developed at week 4 of gestation as 2 buds from the foregut. One is called the dorsal pancreatic bud and one is called the ventral pancreatic bud. Each bud has a duct, the dorsal duct and the ventral duct. The dorsal pancreatic duct is called duct of Santori and the ventral is called the duct of Wersa. At about week 7, there is a rotation of the ventral duct behind the duodenum to lie below the dorsal duct and then to fuse to form a single pancreas. Also, the duct system will fuse, however, it may be delayed. The fusion of the duct is very important, is that the distal part of the dorsal duct, we mean by dorsal duct, the duct of the dorsal pancreatic bud, fuse with the ventral duct. So the ventral duct fuse with the distal part of the dorsal duct, forming what's called the main pancreatic duct or duct of Wersa. This part is the proximal part of the dorsal pancreatic duct, usually regress. However, it may persist and form what's called accessory pancreatic duct. So ideally, we have a main pancreatic duct formed from the fusion of the distal part of the dorsal pancreatic duct with the ventral duct. This is the rule. And usually, the proximal part of the dorsal duct will disappear. However, if persist, it will form accessory pancreatic duct. The first anomaly is pancreatic or pancreas divisum. What's pancreas divisum? It's a congenital anomaly in which there is failure of this fusion, failure of the fusions between the ventral duct and the dorsal part of the dorsal duct. So the ventral duct like this will be isolated, not fused with the dorsal duct. Here what happened? Here all exocrine pancreatic secretions from the body at the tail of the pancreas will be drained through the accessory pancreatic duct. What's the problem? This accessory pancreatic duct is small and also opening at the minor duodenal papillae, not major duodenal papillae. So they could result in pancreatitis. This excretion may be inadequate and could result in some cases in the development of recurrent pancreatitis. Also, the second congenital anomaly is the ectopic pancreatic tissue. Ectopic pancreatic tissue may be found in the stomach, duodenum, jejunum, colon, usually asymptomatic, usually don't cause pancreatitis because they have multiple draining ducts. However, if found incidentally during exploration or laparoscopy, it should be excised for fear of complication. However, if this excision would carry significant comorbidity, it should be left. Annular pancreas. What's annular pancreas? It is a congenital anomaly related to the rotation of the ventral pancreatic duct. Instead of rotating behind the duodenum, the ventral pancreatic pulp will rotate in front of the duodenum, encircling the duodenum, obstructing the duodenum, will cause intrinsic intestinal obstruction to the duodenum, common with duodenal atresia and stenosis and trisomy 21. Characteristic radiological finding is a double bubble sign, and the treatment is to bypass this obstruction with a duodenostomy or gastroduodenostomy. You can refer for more details about this subject in the presentations of gastrointestinal anomalies. Also, cystic fibrosis. We said previously that the cystic fibrosis is related to what's called cystic fibrosis transmembrane regulator gene mutation. And here there will be a viscid pancreatic secretion, viscid pulmonary secretion, meconium ileus, and meconium will be sticky, leading to intestinal obstruction. And we described this in details in other presentation previously. So it's very important to know the congenital anomalies affecting the pancreas in children, whether pancreas divisum, whether to be cystic fibrosis, annular pancreas, ectopic pancreatic tissue. Now we will go to the inflammatory condition. The pancreas is got an inflammation, inflamed, become inflamed. It's acute pancreatitis, acute inflammation of the pancreas. Why? Secondary to a premature and inappropriate intraductal activations of the pancreatic enzymes. We said that the pancreatic enzymes is activated only in the small intestine, secreted in an inactive form. However, here there is abnormalities that cause premature activation of the pancreatic enzymes inside the pancreatic acini and the pancreatic cells. And these activated enzymes will digest the pancreas, and it may vary from a mild condition to severe catastrophic event. How to define pancreatitis in children? Is it different from adults? Yes. Due to limited literatures regarding the pancreatitis, acute pancreatitis in children, the international study group of the pediatric pancreatitis in search for cure reported a statement to define the childhood onset pancreatitis and classify this into acute, recurrent, and chronic, and to systematically characterize the pancreatitis in children. As we see, they put these items, acute pancreatitis. In order to diagnose a child with acute pancreatitis, you should have at least 2 out of the 3 criteria: abdominal pain that is suggestive of acute pancreatitis in the epigastrium, serum lipase or amylase at least 3 times the upper limit of normal, imaging finding characteristic of acute pancreatitis. In order to diagnose a child with acute recurrent pancreatitis, you should have at least 2 distinct attacks of acute pancreatitis. And post-attack must be separated by more than 1 month free from symptoms, with resolution of the pain and also with normalization of amylase and lipase. To diagnose chronic pancreatitis, you should have an imaging suggestive of the chronic pancreatitis and abdominal pain suggestive of chronic pancreatitis, exocrine pancreatic insufficiency or endocrine pancreatic insufficiency, or you find a pancreatic biopsy showing the pathological features of the chronic pancreatitis. What's the pathophysiology? Why acute pancreatitis happened? We said that this is related to inappropriate and early activations of the pancreatic proenzymes to active form, and this active form will digest the parenchyma of the pancreas, followed by accumulations of the cytokines, inflammatory cells, and these cytokines, inflammatory cells mediate inflammation of the pancreas and surrounding tissue. It's very important to summarize the items as we see in this table. Trypsinogen converted to the trypsin, premature and inappropriate will lead to acinar cell damage, leakage of the enzymes, inflammatory cells, cytokines, human necrosis factors were released into the systemic circulation, may end with multi-organ dysfunction or even failure. What's the etiology? What happened to cause this pathology? In adult, it's well established that pancreatitis or acute pancreatitis related to the alcohol abuse or biliary tract disease. In children, the matter may somewhat different, maybe related to the trauma, it's very common, maybe related to the biliary disease, considered the major surgical cause. The idiopathic is still present, and some systemic diseases, some drugs and infections. As we see here in this imaging, this shows that the pancreas, as it lies opposite the lumbar vertebrae, any trauma could result in the fracture of the pancreas, disruptions of the duct, as we see here, with release of the enzymes. Also, some authors claim the child abuse in cases with unclear history, abdominal pain, maybe after child abuse, also the surgical endoscopic intervention. Related to the biliary disease, maybe biliary obstruction, whether functional obstructions or mechanical, by stones, microlysis, hemolytic disorders, or congenital pancreaticobiliary anomalies, most commonly the choledochal malformation. We discussed it separately in a separate presentation. Idiopathic is still the second most common cause. Systemic diseases, up to 30% of the children may be associated with sepsis, shock, hemolytic uremic syndrome. Also, some drugs used for the treatment of leukemia or epilepsy may be associated with pancreatitis. Infection with the head, most commonly the mumps, may lead to acute pancreatitis. So pediatric surgeon should be familiar with these causes. How to diagnose acute pancreatitis? It's important to go through the history of the abdominal pain. Classic abdominal pain is a sharp, sudden, constant, and located in the digastrium. However, the radiation to the back described in adult may be uncommonly elicited in the children. Followed by the physical examination. The child usually irritable with a distended, tender abdomen, maybe fever, tachycardia, or hypotension. Also, pain relief if the knee is drawing up to the flexed trunk is a sign. There is maybe ecchymosis around the umbilicus or plouch discoloration, which is called Collin sign, or in the flank, which is called Gray-Turner sign. However, these ecchymosis take about 1 to 2 days to develop. The laboratory result of ultimate importance to know that amylase and lipase. Amylase is diagnostic in the acute pancreatitis. It requires to be 3 times above the normal. It rises within a few hours and normalizes within 3 to 5 days. It's helpful, although the normal serum level doesn't exclude the diagnosis, and you should know what are the other causes for elevation of the amylase. hyperamylesemia may be present in the salivary inflammation or trauma. Some intestinal diseases with perforation, ischemia, necrosis may result in elevated amylase. On the other hand, lipase is more specific for infant and children. It rises within 4 to 8 hours of symptoms, usually using post-lipase, and the diagnosis reach very high sensitivity for diagnosis of acute pancreatitis. However, you don't miss the other causes of elevations of the lipase, may be elevated in the pancreatic cancer, maybe renal insufficiency, cholecystitis, intestinal perforation. Regarding the imaging, the plain radiograph of the abdomen and the chest may show dilated lobe of the intestine related to the pancreas, known as a sentinel lobe. Also, the chest radiograph may show evidence of pleural effusions, pulmonary edema, which may be associated with pancreatitis. The ultrasound may evaluate the biliary stone disease as an etiology, may show a choledochal cyst or pancreatic pseudocyst. Abdominal CT allow for a better visualization, usually diagnose the complication as a pseudocyst, usually used in cases of recurrent pancreatitis and may be combined with interventional procedure. The MRCP, magnetic resonant cholangiopancreatography, is a non-invasive technique, evaluates the ductal anatomy very well in a children with unexplained or recurrent pancreatitis. However, it doesn't allow for the therapeutic intervention, may also direct the type of the therapy needed, limited visualization of the smaller duct in children, and may require anesthesia in the pediatric age group. Regarding ERCP, is RCP indicated? No. ERCP is not indicated in acute pancreatitis because already it has an associated risk of post-procedural pancreatitis. However, can be useful in some patients with a pancreatic duct disruption secondary to trauma for diagnosis and stent placement, may be useful for idiopathic recurrent pancreatitis to diagnose the cause, may be useful for a pancreatitis associated with cholangitis or cholecystitis if the anatomy is not well described with MRCP. Regarding the scoring systems, it's known that the Ranson score and Glasgow scores are well established in adults. However, when we apply these scores to children, some items cannot be applied, like age above the 55 years, like fluid deficit of more than 6 liters. So this difference leads some pediatric surgeon to propose develop scores for children. The DPANTO developed pediatric acute pancreatitis score, PAPS score, with 8 variables, 4 at the admission and 4 by 48 hours. Also, Al-Azhar score developed score related to the radiological assessment of the pancreas. Radiological appearance include the enlargement, the peripancreatic inflammation, and the pancreatic fluid collection and the extent of necrosis. As we seek to revise, this is a Glasgow prognostic score, Ranson criteria at admission and after 48 hours, can be applied in children, however, with some limitation, as some items cannot be applied in children. Also, Al-Azhar score, normal pancreas or enlargement or inflammation, peripancreatic inflammation, and will give percent of necrosis, whether 0, whether 30, 30 to 50, and then the severity index, low degree or middle degree or high degree, according to the point. The question now, how to treat acute pancreatitis. Actually, treatment of the acute pancreatitis is not changed over many decades. Treatment related to the fluid, pain control, nutrition, antibiotics, and finally, whether to perform endoscopy, surgical intervention or not, and to treat complication. Aggressive fluid resuscitation of ultimate importance because the patient usually volume depleted, vomiting, third space loss of fluid, increased respiratory loss. So the early resuscitative measures, usually with crystalloids within the 12 to 24 hours, is of ultimate importance, and the benefit will decrease after. Adequate pain control. However, prior to starting any narcotics, you must sure of your diagnosis of acute pancreatitis, because using of these narcotics will mask the other symptoms of serious pathology, like perforation, like ischemia. So be careful when using these narcotics. The mebridine is preferred over morphia, as a morphia may cause spasm of sphincter of Oddi. However, some other authors claim that the mebridine itself may have a side effect in children, so there is a debate of the ideal narcotic to be used in children. The nutritional management. There is paradigm shift in the nutritional management from using total parenteral nutrition to nowadays to use enteral nutrition. Early nutrition is essential. Number one, enteral is preferred over the total parenteral, because the total parenteral reported in the literature to be associated with increased length of hospital stay and delayed advancement of diet. On the other hand, the enteral nutrition decrease the length of the stay, reduce the need of surgery, and reduce the risk of infection. Regarding antibiotic, there is a debate regarding the role of the prophylactic antibiotics in acute pancreatitis. Some adult data suggest that the use of antibiotic decreases the mortality and infection, but these all studies fail to reach significant statistical result. Antibiotics may be used in the presence of the extrapancreatic infection, infected pancreatic necrosis, and in cases with a clinical deterioration. And when antibiotics are initiated or indicated, the quinolones, metronidazole have the best pancreatic penetration. What's the role of the surgery? It's a very important question for all pediatric surgeons to know that the most episodes of acute pancreatitis in children resolve with medical management alone, and surgery rarely indicated. Regarding endoscopic intervention, ERCP may need to identify or remove the obstruction by the stone. The ERCP may remove the stone, may dilate or stent adduct structures, may perform a sphincterotomy, may take a biopsy from suspected mass. So the ERCP may be indicated in some situation. However, the operative exploration is usually not necessary in acute pancreatitis. However, may be indicated with infected necrotic pancreatitis or a pancreatic abscess. However, adult data suggests that even infected necrosis or pancreatic abscess should be treated in a stepwise manner, starting from the least invasive to the more invasive. So they recommend to treat these conditions at first with a percutaneous drainage, if failed, to perform minimally invasive necrosectomy, and if failed, delayed operative intervention or delayed necrosectomy. They show that these measures carry a better prognosis than to perform primary necrosectomy from the start. How to treat complications with acute pancreatitis? We know pancreatic pseudocyst, pancreatic ascites, necrotizing pancreatitis, fistula, and hemorrhage. Regarding pseudocyst, all of us know that the pseudocyst result from accumulation from the leaked pancreatic enzymes due to pancreatic trauma or acute pancreatitis enclosed within an inflammatory non-epithelial lining. So it's called a pseudocyst. This pseudocyst may produce hemorrhage by erosion into a nearby vessel. Visceral vessels may rupture and infection, although uncommon. We may have an acute pseudocyst, which is a thin, irregular wall, and half of this resolve without treatment. And we may have chronic pseudocyst, spherical, thick wall, and need intervention. So the differentiation between the two types is of ultimate importance for the pediatric surgeon. The treatment for the pseudocyst, those then at least 5 cm in diameter, usually regresses spontaneously. However, if persists or become symptomatic, may require endoscopic treatment, and this is well established in adult, and some centers nowadays use it in children with expert endoscopist, pediatric endoscopist. Internal drainage to the stomach and the jejunum, if possible, maybe by open surgery or laparoscopic, and also the percutaneous drainage, usually for the infected pseudocyst, because they have a thin wall, not amenable for the anastomosis and internal drainage. Regarding pancreatic ascites, Maybe at the complication of pancreatitis, there is a free fluid leakage from the major pancreatic duct, and here the CT, ERCP, and MRCP is performed to assess for the ductal injury. And the literature is full of controversy regarding what is the optimal treatment of the pancreatic trauma with a ductal injury, operative versus non-operative treatment. I try to summarize the debate in this table. Non-operative management mean power rest, hyperelimination, long-acting somatostatin. Some series of the report more complication with this regimen, longer time to feed, higher rate of pseudocyst formation, and the other support this regimen of treatment. On the other hand, operative management, what to do? Drainage alone may be sufficient in some cases. Distal injuries treated with a distal pancreatic resection, and some literature describes as may be performed laparoscopically. Proximal injuries require to perform anastomosis with the intestinal loop, pro-NY jejunal onlay anastomosis to preserve the pancreatic tissues, and the pseudocyst is common complication in such cases. Another item is a necrotizing pancreatitis, which means that there is a pancreatic parenchymal necrosis or peripancreatic tissue necrosis. And this necrosis may be infected or sterile. The patient here will be managed with a supportive care unless there is evidence of infection or ductal obstruction. Pancreatic infection can be suspected on the CT scan when air is detected in the area of necrosis, like here. You can show this CT scan. There is entire pancreas replaced by acute necrotic collection which contain large amount of air. Here, there is infected only peripancreatic necrosis with some gas bubbles, but the pancreas itself is intact and without necrosis. How to treat pancreatic necrotizing pancreatitis? Antibiotic is the first line of the treatment. Drain insertion to obtain a source control of the infection, and surgical debridement if the patient doesn't respond. As usual, we start with the minimally invasive approach, percutaneous, endoscopic, laparoscopic, retroperitoneal approach, and followed by, if failed, by open debridement and necrosectomy if the patient doesn't respond or has a rapid clinical deterioration, uncontrolled sepsis. So the trend nowadays in most literature is to treat even complications of acute pancreatitis with a stepwise manner, starting with a less invasive. At first, to perform interventional procedure, laparoscopic procedure, and finally, if this method or measures fail, you can shift to the primary open debridement and necrosectomy. It's important for the pediatric surgeon to be aware of these changes in the management of these types of complications. Regarding fistula, pancreatic fistula, usually post-operative or after non-operative management, most low output fistula close spontaneously provided that the tract is not obstructed. However, it may drain for several months. There is a trial of use of long-acting somatostatin analog to decrease the fistula output and accelerate the rate of the closure. But it don't induce closure of the fistula that wouldn't otherwise closed. To manage a pancreatic fistula, maintain nutrition with hyperelimination. If the enteral feeding will increase the fistula output, ensure that the fistula tract doesn't become obstructed. Operative intervention may be with raw NY jejunostomy to be anastomosed to the site of the fistula if the fistula fail conservative management. Finally, pancreatic hemorrhage, treated by fluid resuscitation, correction of associated coagulopathy, severe hemorrhage that may require embolization or surgery. So this is how to treat a complication. So don't forget to go through the resuscitation, pain control, and go through the diagnosis, treatment of the complication, role of surgery, or endoscopic management. Majority of the cases of acute pancreatitis, the scenario will end at this point and the child will get well. However, some children may develop what's called acute recurrent pancreatitis and chronic pancreatitis, as we discussed in the previous table. Acute recurrent pancreatitis, as we said, that the INSPIR consortium proposes this term for the more alternative to the commonly used recurrent acute pancreatitis. Why? Why they prefer to use acute recurrent pancreatitis and not recurrent acute? Because they said that the abbreviation RAP, recurrent acute pancreatitis, is commonly mistaken with recurrent abdominal pain in children. So to avoid this confusion, they prefer to name it as acute recurrent pancreatitis, ARP. Children presenting with recurrent pain and pseudocyst are not considered as acute recurrent pancreatitis because this is a complication of the acute pancreatitis. The management of the acute recurrent pancreatitis in children is non-specific and partially overlap the acute pancreatitis, follow the same items. However, it's important to study these children in detail to identify the possible causes of this recurrence. Maybe choledocholysis, maybe congenital anomalies, maybe systemic or genetic disease to treat it probably. Now, chronic pancreatitis, very important topic for children. Here, there is irreversible damage to the parenchyma, to the destructions, sclerosis of the pancreatic tissue, with ultimately pancreatic insufficiency in a child. So what happened? Is it a sequelae of acute pancreatitis? Maybe. Is it a sequelae of acute recurrent pancreatitis? Maybe. However, most literature describe that no, there is a systematic or genetic predisposition of this child to have a chronic pancreatitis. It is not usual for acute pancreatitis to end with a destruction, although it may happen. In a chronic pancreatitis, there will be severe intractable pain. There will be malabsorption, no digestion of the carbohydrates, proteins, fats, deficiency of enzymes, maybe complications, maybe 13-fold risk of the cancer, maybe diabetes due to proximity of the endocrine to the exocrine pancreas, so the destruction will extend to the endocrine part. What's the etiology? To be clear, it's classified into whether hereditary or idiopathic pancreatitis, obstructive, or some conditions of what's called pancreatic dyskinesia. In hereditary pancreatitis, nowadays there is understanding if there is a genetic background for some cases with a familial pancreatitis affecting more than one generations with inflammation and destructions of the pancreas. Maybe genetics, maybe sometimes an autoimmune destructions of the pancreas. The most common genetic causes is known as a cationic trypsinogen gene, PRES1 gene mutation. This will result in prevention of the degradation of the prematurely activated trypsin and also may make the trypsin resistant to inactivation. So the trypsin will destruct and digest the parenchyma and the structures of the pancreas. So genetic testing is very important in children with recurrent or idiopathic pancreatitis with or without family history. Importantly, that patients with hereditary pancreatitis have a marked increased risk of pancreatic cancer after the age of 50 years. It's very important. The second type is obstructive pancreatitis causing chronic pancreatitis due to anatomical or functional obstructions of the duct. Most common, as we said previously, pancreas divisum. However, there is a debate in the literatures. Why a minority of the patients with pancreas divisum develop pancreatitis and others don't? And the literature go in the debate that is depend on the anatomical variation, maybe associated with structural narrowing of the minor papillae, not only that the pancreas is drained through a small duct. Maybe these children may have sphincter of OD dysfunction and may be associated with a cystic fibrosis transmembrane regulator mutation. So this obstruction could result in chronic pancreatitis. Pancreatic dyskinesia is described in the literature, although it's not well studied in children and may be improved with endoscopic sphincterotomy, sometimes with a stent placement, temporary stent. For those, endoscopic treatment is not visible or fail. Individualized surgical treatment of dyskinesia is reasonable based on the patient ductal anatomy, the level of the obstruction, and the severity of the pancreatic fibrosis. What's the clinical presentation of the chronic pancreatitis? Number one, characteristic pain. Number two, diminished pancreatic secretions with insufficiency and diabetes. The diabetes in the patient with the chronic pancreatitis described as being brittle or fragile diabetes with high or hypersensitivity to insulin. This may be explained in the literature by the proximity of the alpha cells to the beta cells. So there is destructions of both alpha and beta. Alpha produces glucagon, which has opposing actions to the insulin. So even with a very low dose of insulin, there will be severe hypoglycemia in these children. Radiological abnormalities, the CT scan will show, like here, microcalcifications in the duct of the pancreas. Dilated obstructed duct is also an obvious finding in some cases of chronic pancreatitis, like here, this MRCP and ERCP showing dilated and obstructed pancreatic duct. So it's very important to evaluate the ductal anatomy in all cases of the chronic pancreatitis to show there is a dilated, obstructed duct. This is called ductal hypertension and they need drainage procedure to drain this obstructed and dilated duct. So the MRCP and ERCP is both helpful in the diagnosis and management. There is recently what's called secretin-enhanced MRCP. What is secretin? It is a hormone, usually increase the secretions of the cells lining the ductus of the pancreas. So it's used to make the image more clear and also to estimate what's called pancreatic flow rate. In a Chinese study of 53 subjects, post-normal and with chronic pancreatitis, the flow rate of about 8 milli per minute regarded as normal, and those with severe chronic pancreatitis only achieve a rate of about 4 milli per minute. So this secretin-enhanced MRCP is a new modality that helps to more clear image by giving secretin, which is a potent stimulant to the pancreatic ductal secretion, water and bicarbonate, and also to estimate what's called pancreatic flow rate, whether normal or severely affected in chronic pancreatitis. How to treat chronic pancreatitis? The treatment directed toward palliation of symptoms, control of the severe pain, control of diabetes, steatorrhea, treatment of the acute exacerbations. In general, this patient will benefit from a small, frequent meal. However, the major question and the important one, what is the role of surgery in the cases of the chronic pancreatitis in children? Prior to any surgical intervention, it's important to demonstrate the ductal anatomy to see if there is a dilated, irregular, obstructed duct with a ductal hypertension or not. Some school of surgeon or some literatures describe that you should first try endoscopic dilatation and pancreatic stent for this ductal hypertension or obstructed duct. You try to put a stent or to perform dilatation by interventional endoscopy. If the patient relieves some relief of pain, or if there is a relief of pain, this patient type would benefit from surgery. If there is no response to the stenting, this patient unlikely to benefit from drainage surgery. However, this school is not uniform, and other series and other pediatric surgeons claim the opposite, that the failure of the endoscopic visualization or failure to control the severe pain or the presence of the dilated main duct or a ductal hypertension seem to be the indication to surgery. So some claim that first try interventional or endoscopic dilatation and stent. If the patient shows some improvement, proceed to surgery. Others said no. the failure to improvement or failure to control is the indication of surgery, and the presence of the dilated duct is the indication of surgery. How surgery, the chronic pancreatitis, be classified? We may have three types. We can use one or combined of them, whether drainage procedure to drain this dilated, engorged pancreatic duct and decrease the duct hypertension, whether to resect, remove the inflamed part of the pancreas. We may have a head dominant inflammation. We may have a body and tail dominant. So you will excise this area of the pancreas. So we may have drainage procedure, resective, or finally denervative to denervate or relieve the neurogenic aspect if above measures fail. We give an example of the drainage procedures. This is described technique called modified post-2 technique or lateral pancreatico-jejunostomy. Pro-in-Y lobe of the jejunum is anastomosed to the dilated duct after opening it longitudinally. So we open the dilated obstructed duct, but anastomotic only with the lobe of the jejunum, aiming to what? To decrease the pressure, to get away for the pancreatic secretions to be delivered to the intestinal tract. So we try to perform a lateral anastomosis of the opened out the duct to the lobe. Actually, this technique passes in two stages. Original technique described in 1958 by the Charles Pestou. At first, the authors performed separate the pancreas and pancreatic vessels with and splenic vessels with splenectomy, open the duct longitudinally and invaginate the whole of the pancreas into the lobe of the intestine. This is the original. However, it's modified by the Rochelle and colleague, modified into what's called lateral pancreatico-jejunostomy. This is the most commonly used today. Lateral pancreatico-jejunostomy to leave the pancreas in situ, just to open the pancreatic duct longitudinally and bring the lobe of the jejunum and anastomose the lobe to this opened duct, as we see in the previous image and here. This is a way of what? Of drainage procedure, of decompressive procedure to get away for the accumulated pancreatic secretions to reach the small bowel. Other procedure for the same category is the Duval procedures. This is the least invasive, draining only the tail of the pancreas with the Roux-en-Y. However, it's very prone to recurrence. On the other extreme is a Frey procedure. Frey depend on the extending the duct incision to involve the uncinate and the head of the pancreas, and anastomosis will be extended to this. However, all these types are a drainage procedure or decompressive procedure, trying to decrease duct hypertension and get away for the accumulated secretion. Resective procedure, yes, to excise the diseased area in the pancreas, whether a head dominant or body and tail dominant, according to the situation. Eliminate the area of the chronic inflammation by excision of localized pancreatitis. We can perform distal pancreatectomy if the diseased portion of the pancreas localized to the tail. Duodenum or pyloric preserving Whipple in some cases of extensive disease. So in extensive disease, we may perform like Whipple procedure, excise whole the pancreas, leaving small rim of the pancreatic tissue adherent to the duodenum, so not to excise the duodenum and preserve the duodenum or preserve pylorus and duodenum preserving surgery. Although the operative result in hereditary pancreatitis are generally disappointing, evidence showed in the pediatric literature that patients treated with modified PIS2 procedure may show improved quality of life, pancreatic function, and the nutritional state. And also, unlike adults with hereditary pancreatitis, some reversal of steatorrhea may be seen in children after this procedure. Very important to understand well acute pancreatitis, presentation, complication, how to diagnose, how to manage chronic pancreatitis. What is this? What's the cause? What's chronic pancreatitis? Is it a sequelae or this children is genetically predisposed? There is a genetic predisposition to the development of the chronic pancreatitis. Now we will go to an important topic of the presentation today, which is a functional pancreatic disorder, and unit born with a severe hypoglycemia that is not corrected. Severe hypoglycemia may be transient or persistent. So the major causes of the persistent hypoglycemia in the newborn and young infant are a congenital hyperinsulinism, CHI, glycogen storage disease, insulinoma, if the onset after 1 year of age, inadequate gluconeogenic hormones like hypothyroidism or growth hormone deficiency. Let's go in details in the first one, congenital hyperinsulinism of infancy, and what's the surgical rule in these cases. It's a genetic disorder of the insulin secretion and glucose homeostasis. There is a problem in the insulin secretion. There is inappropriate insulin secretion or insulin action, resulting in a severe, persistent neonatal hypoglycemia. This disease may affect only small area of the islets of Langerhans called focal congenital hyperinsulinism, or may affect the whole pancreas, entire pancreas, called diffuse hyperinsulinism. Let's see. What's the pathogenesis of the congenital hyperinsulinism? Previously, it was considered that there is insulin over-secretion due to abnormally high number of the islet cells, condition called nesidoplastosis. They consider that there is many islet cells secreting more insulin, leading to this hyperinsulinism. However, the later studies showed that no, it's not an over-secretion, it is a genetic abnormality in the regulatory control of the insulin secretion and glucose homeostasis. Let's see. To summarize, during postprandial state, when we eat, the plasma glucose concentration rise and the glucose will enter the beta cells of the pancreas, and this will and this will initiate a chain of event. Final result is an insulin secretion. Let's see. These diagrams summarize when we eat a carbohydrate, the glucose will elevate in the blood. Glucose will pass into the beta cell. This is a beta cell of the pancreas. Through the GLUT2 gate. After that, the glucose will under a process of what's called glycolysis, with productions of large amount of the ATP. And this increased ATP and ATP-ADP ratio will stimulate what's called potassium channel gate or potassium channel. This will be closed by high potassium inside the cells, accumulate high potassium inside the cells. This high potassium will lead to depolarization of the cell membrane and will open the calcium gate. Second gate, calcium influx to the cell will lead to stimulate the insulin vesicles stored to adherent to the beta cell wall and release its content to the blood, called insulin exocytosis. So this is the normal process regulated by the feedback about the blood glucose. So this glucose, when be high, will enter the cells, increase ATP, stimulate this potassium channel to close, and then the potassium increase, depolarization, open the calcium channels, insulin vesicles will adhere to the wall of the beta cell membrane and release the insulin into the blood, insulin exocytosis. When the blood glucose level decrease, the process stops. However, if this process is not stopping, there is a continuous secretion of insulin. Let's see. This is the same as we said, the increased plasma glucose enter the beta cells, increase intracellular concentration of the ATP. This inactivate and close the ATP-dependent potassium or sensitive potassium channels. This will lead to depolarization inside the cells, activate the calcium channels. Calcium influx triggers insulin exocytosis. Exocytosis means that the insulin vesicles is adherent to the wall and release insulin into the blood. The potassium ATP channels of the beta cell membrane composed of two subunits, one called SIR1 and second is KIR6.2. These two subunits is encoded by the two genes present related to each other on the region 15 on the chromosome 11. This genes is called APCC8 and KCNJ11. Very important to remember these two genes, ABCC8 and KCNJ11. This is important for coding the genes responsible for the function of what? Of ATP sensitive potassium channels. Let's see. In the congenital hyperinsulinism or hyperinsulinism of infancy, there is a genetic mutation that cause loss of the function of the ATP-dependent or sensitive potassium channel of the beta cell membrane. So this gate will close all the time, accumulating potassium inside, depolarization, opening the calcium channel, insulin secretion. The KATP channel remain closed all the time, but regardless of the plasma glucose level. We said that this process is regulated by the level of the glucose during postprandial, whether during fasting. Here, the channel is closed all the time, regardless of the plasma glucose generating non-regulated persistent insulin release that lead to severe and fatal hypoglycemia in a neonate. Let's see what happened here. No increase, no carbohydrates, no increase in the glucose, no glucose entering the cells. However, this is still closed, genetic mutation here, and there is still closed, the depolarization present, calcium enter, and the insulin release to the circulation. So the pathophysiological mechanism of the congenital hyperinsulinism is a loss of function due to genetic mutation affecting the two genes encoding for the potassium ATP channels. The potassium ATP channel remain closed all the time, regardless of the plasma glucose. Potassium accumulate inside the inner surface of the beta cell, depolarizing it, activating the calcium channels, allowing the calcium to enter and accumulate in the cytoplasm, trigger insulin cytosis, non-regulated persistent insulin release that lead to severe hypoglycemia. So imagine a child born with continuous insulin, neonate with continuous insulin, severe hypoglycemia, severe persistent hypoglycemia. So what's the types of the genetic mutation? The types, the most common, as we said, is the mutation in ABCC8 and KCNJ11 genes that is responsible for the functions of the gate, potassium ATP gate or channels of the beta cell membrane. Maybe other genetic mutation, yes. Maybe mutation in the other genes and other enzymes and the metabolic factor involved in the glucose metabolism. There is abnormalities in the glucokinase, hexokinase, glutamate dehydrogenase, hydroxy-CoA dehydrogenase, hepatocyte nuclear factor 1 alpha. So the gate may be normal. However, the mutation affecting other steps in the glucose metabolism and the enzymes involved in the glucose metabolism. So there will be still a severe release of insulin and there is no glucose production. Diffuse type of the, as we said, there may be a diffuse form, whole pancreas is affected. In this diffuse time, there is a mutation in the ABCC8 and KCNJ11 genes that cause loss of function in the both subunits of the channels SER1 and KER6.2 as an autosomal recessive manner, or maybe mutation in the genes of the other enzymes and metabolic factors. So these two mutations could result in a diffuse form of congenital hyperinsulinism. On the other hand, the focal form may occur as a two-hit phenomenon or as a two-component, maybe mutation in single paternal allele of the genes of the SER1 and KER6 complex. Maybe mutation in the paternal, we mean from the father. The gene inherited from the father may be mutated that code for the functions of the potassium ATP channel. So it may be mutated. This is number one. Or maybe the mother. In the mother, the segment, we said that the genes are present on the segment P15 of the chromosome 11. So this segment may be lost completely. Not mutation here. Loss of the segment from the chromosome 11 from the maternal allele. So here, The beta cells will oversecrete insulin as we discussed, plus it will be show adenomatous hyperplastic proliferation due to imbalance in the gene that controls cell proliferation that also contained in this lost segment. So imagine that in the focal congenital hyperinsulinism, maybe due to mutation in the genes from the father responsible for the function of the potassium ATP channel, or maybe that all segment in the segment B15 in the chromosome 11 in the mother is lost. So there will be congenital hyperinsulinism, yes, plus another pathology, which is adenomatous hyperplastic proliferation due to loss also of the series of the genes that control cell proliferation. So here you will find hyperinsulinism with a mass, adenomatous hyperplastic proliferation in this affected beta cell. I hope to be clear. This table illustrates the common genetic mutations, loss of the function mutation in the SER1 and KER62. This is a component of the ATP-sensitive potassium channel, resulting in continuous depolarization, dysregulated insulin, which is a commonest mutation in the genes of the other enzymes and metabolic factors with some characteristic mutation in the glutamate dehydrogenase gene, resulting in mild form associated with hyperammonemia and epilepsy. Heterogeneous mutation in the islets transcription factor gene through unknown mutation, and rare causes mutation in the glucokinase hydroxyacyl coenzyme E dehydrogenase. How to diagnose congenital hyperinsulinism? Infant usually macrosomic, large weight for birth, develop hypoglycemia shortly after birth, although it may be manifest later. Symptoms may be mild, some lethargy, irritability, or maybe severe with apnea and seizure. Simultaneous insulin and glucose measurement show what? High rate of insulin to glucose. It's important. High rate of insulin to glucose. This glucose don't lead to this amount of insulin. The release of this amount, insulin level may be normal, but inappropriate in the presence of hypoglycemia. We are in hypoglycemia. Why the pancreas secrete insulin? We don't need insulin. Insulin released in response to high blood glucose. Here we have a low blood glucose. Why this insulin is released? It's very essential to understand this point. So there is a high insulin to glucose. The insulin level is inappropriate in the presence of hypoglycemia. To differentiate this from insulinoma, very important observation. Blood test, we can use fasting and postprandial hypoglycemia, plasma glucose level less than 50 milligram per deciliter after the first 24 hours of life, and the plasma insulin more than 36. The second point is very important. Suppression of lipolysis and ketogenesis at the time of hypoglycemia. Normally, during hypoglycemia, the body started to give a glucose from what? From lipolysis, extractions of the lipids to get more energy, to get glucose. However, here, there is no lipolysis. Here, there is no lipolysis due to inhibition of this process by insulin. During fasting state, no insulin released, and there is a stimulation of lipolysis to give a more glucose. Here, there is hypoglycemia with insulin. So there is a suppression of lipolysis and ketogenesis at the time of hypoglycemia. Normal physiological response to hypoglycemia and are physiologically inhibited by insulin. So why there is no lipolysis and ketogenesis in the cases of the congenital hyperinsulinism? Due to the presence of the insulin. And this insulin inhibits this process even in the presence of hypoglycemia. The third one is a positive glycemic response to the dose of glucagon. We said that the glucagon is physiological antagonist or direct insulin antagonist. Glucose must increase by 30 to 50 after 0.25 to 1 milligram of intravenous glucagon. So this is diagnostic of congenital hyperinsulinism, that the hypoglycemia is due to the presence of high insulin. When you give a glucagon, there is a positive increase in the blood glucose level, positive glycemic response. However, take care, these criteria must be present for a prolonged period of the time and outside certain clinical circumstances as prenatal stress and sepsis. We will speak now about the other causes of the hypoglycemia in children. It's very important to be understood. How to treat congenital hyperinsulinism? The priority in the treatment here is to protect the brain from severe catastrophic hypoglycemia. You need urgently to reach to euglycemic state. Otherwise, the brain will be affected. So this is achieved at first with high concentration intravenous glucose infusion and frequent enteral feeding, hyperglycemic drugs. You should give to reach normoglycemia. You must protect the brain. Intravenous glucose, the preferred is dextrose, 10%, and calculated as this equation, intravenous rate, and can be as high as 30 milligram per kg per minute, which is more than 3 times the physiological hepatic glucose release during fasting state in the newborn. Hyperglycemic drugs, yes, there is some drugs will cause hyperglycemia, and the main drugs is called diazoxide. Diazoxide is a very essential drugs and considered by the WHO as an essential medicine to be present everywhere in every hospital. It's very essential. Diazoxide inhibit the insulin secretion by activating the potassium ATP channels. Activating the channel, yes, this is a normal function. However, it requires to be effective that the channel post subunits SIR1 and KER 6.2 to be functional and structurally normal. So this drug to be effective needs this channel to be normal. However, we said that the etiology of the congenital hyperinsulinism is the genetic mutation, and this channel is not normal. It will not respond. So the majority of the cases, surprisingly, the majority of the cases with the congenital hyperinsulinism will not respond to the diazoxide. It's that children with congenital hyperinsulinism classified into diazoxide responsive group and diazoxide resistant, which is the most common. However, what diazoxide responsive? We said that the cause of the congenital hyperinsulinism may be mutation in the genes coding for the functions of ATP, potassium channel, and there is a second mutation in the genes control other enzymes and metabolic factor involved in the glucose metabolism. So if the child is due to other mutation, it may respond to this diazoxide. So let's see. Since the most common cause of the congenital hyperinsulinism is a mutated complex gene controlling potassium ATP channels, most congenital hyperinsulinism children don't respond to the diazoxide. Only children who respond to the diazoxide are those with a mutation in the other related genes, as we said. How to evaluate the response to the diazoxide? It's an important question. How to evaluate responsive, not responsive, partially responsive. After 5 consecutive days of the diazoxide administration with already intravenous glucose, response is evaluated by fasting test, what's called fasting test of intravenous glucose and other hyperglycemic medications. Fasting from the diazoxide and hyperglycemic medication, and we follow infant who can maintain the fasting a plasma glucose level of more than 70 milligram per deciliter for at least 12 hours of the fasting test, consider diazoxide responsive and discharged home on long-term diazoxide treatment with frequent feeding regimen. So this is the first category. infant who can maintain plasma glucose level more than 70 after 5 consecutive days of the diazoxide administration. Number 2, infant who can maintain plasma glucose level above 70 for several hours only, but don't reach the 12-hour mark. Consider to have partial response to diazoxide and managed with combination of diazoxide and frequent or even continuous feeding. The third one is very important for pediatric surgeon. Infant who plasma glucose level full below 70 within first hour of fasting test. Consider diazoxide resistant. And here, diazoxide is discontinued. Intravenous glucose is reestablished immediately to preserve euglycemia. Alternative drugs tried to maintain euglycemia may be tried as a stabilizing agent prior to the surgical intervention to reverse profound hypoglycemic episode. So in cases of the diazoxide-resistant cases, we can try some other drug as a bridge, as a temporary measure before surgery. Like octreotide, it's a long-acting somatostatin analog, inhibits the insulin secretion by direct action on the calcium voltage channel. Given subcutaneously every 6 to 8 hours or as a continuous intravenous infusion, but it must always be increased. The level needs to be increased because of its rapid desensitization. It's not recommended for a long-term treatment due to many side effects. So it's used as temporary measure before surgery. And also glucagon. It's a natural insulin antagonist, can be preoperatively given or as a continuous intravenous infusion to help in maintaining euglycemia or as intravenous bolus to rescue patient from severe hypoglycemic episodes. So at first, diazoxide is essential medicine as described by the WHO. The diazoxide is given the children or infant classified into responsive, resistant, partial responsiveness. In a case of resistant, you can choose the other two drugs as a temporary measure before surgery. Now, what about the preoperative planning for surgery? What is the preoperative planning? The most important question here is whether this child or neonate has a diffuse or focal congenital hyperinsulinism, as the treatment is radically different and the clinical presentation is different. So the first step to answer this question is to perform genetic testing. If there is a confirmed genetic mutation of the potassium ATP, diffuse congenital hyperinsulinism, don't need preoperative imaging studies, as this will subjected to near total pancreatic. So the result of the genetic testing, if showed confirmed potassium ATP channel mutation or diffuse congenital hyperinsulinism, this child don't need preoperative imaging studies as we prepare the child for near total pancreatic. If the genetics suggestive of focal congenital hyperinsulinism, suggestive that is only there is a focal area, there is only mutation in the parental allele, the regions 15 in the chromosome 11 may be lost from inherited from the mother, and there is adenomatous enlargement in the size of these cells. So if the genetics suggesting that there is a focal, imaging study here is very essential to localize where is the lesion. If there is unknown or unclear genetic imaging study to determine if it is focal or diffuse is important to diagnose by imaging studies. What are the pre-operative imaging studies? Unfortunately, the conventional imaging, like ultrasound, CT, MR, used without much success. Also, the invasive test, like arterial stimulation, venous sampling, portal venous sampling to show high insulin and the glucose level, usually takes several hours and technically very demanding, and their sensitivity and specificity are very low to differentiate focal from the diffuse disease. The most used today is isotope scan, 18-fluoro-L3-4-dihydroxyphenylalanine positron emission tomography with a low radiation CT, PET CT scan. As the beta cells will take up the L-dihydroxyphenylalanine, L-DOPA, and converting it to L-dopamine by the enzyme DOPA decarboxylase and store it in the insulin vesicles. Similarly, the beta cells can take this fluorotype that can be followed by the gamma camera and traced. And we can find this picture. Like this, in the focal, the tracer will be accumulated and detected in the area of hyperactivity, demonstrating the focal lesion. Unlike here, there is a diffuse uptake of the tracer all over the pancreas. So this DOPA PET CT scan is the most important used study today. Some claim the use of gallium studies in the diagnosis of congenital hyperinsulinism. However, there is no approved result in pediatrics. Now we will go to what's the principles of the surgical intervention. Rapidly, the incision is a transverse supraumbilical, the pancreas completely exposed by the extended Kocher's incision and entry into the lesser sac mobilizes the hepatic flexures of the colon toward the infant left side, as we see. How to identify the focal lesion intraoperative? Very important question for all pediatric surgeon and the pediatrician. How to identify the focal lesion, regardless of the result of the preoperative genetic testing or imaging studies. The pancreas intraoperative is inspected with 3.5x loop magnification or even 4x and is carefully palpated to identify a focal lesion. It's number one. Number two, the focal lesion often have a subtle appearance or subtle difference in the appearance or textures compared with the normal tissue. The focal lesion usually firmer, more harder than the normal pancreatic tissue. As we see this image, the focal lesion generally less than 10 millimeter in diameter, but can be much larger. The focal lesion usually irregularly shaped and frequently have an octopus-like tentacles, like dilatation with the projections, multiple projections. So these projections may mislead the frozen section to the end of the focal lesion, which make intraoperative frozen section confirmation of the clear margin is very essential. You should confirm intraoperatively you reach the clear margin because the focal lesion is usually with multiple projection, octopus-like tentacles with multiple projections. So it cannot be excised with a clear margin very easily. You need multiple biopsy to ensure that there is no missed projection in the pancreatic tissue. The second question is what to do if the focal lesion cannot be identified. We said that the preoperative PET CT scan generally facilitates the search. Whether focal or generalized focal lesions can be identified well with the PET scan, DOPA scan. Intraoperative high-resolution ultrasound is very helpful in localizing the focal lesion, especially if the genetic, confirming that this neonate diagnosed with a focal genetic mutation of the focal type. The focal lesions that is paired within the pancreatic tissue can be impossible to see or fill, so it's necessary to take additional biopsies of the suspicion area for the frozen section analysis unless the lesion is found. Expert pediatric anatomic pathology interpretation is very essential. So it's very important to know how to identify the focal lesion. Appearance, firmer textures, lobe magnifications, preoperative investigations, PET CT scan, intraoperative high-resolution ultrasound, intraoperative multiple frozen section biopsy and examination with an expert pathologist. What to do for a focal lesion? You diagnose the focal lesion, then you decide to perform treatment, partial pancreatectomy, Disease-free margin must be confirmed. Remove the area of the focal affection with a clear margin. If there is a small and superficial region in the body on the tails, treated by simple resection. Deep lesions, distal pancreatictomy. Superficial and small lesion in the head, simple local resection. However, the problem with deep lesions in the head, it's usually challenging and difficult to excise within a clear margin because you fear from injury of the common bile duct or pancreatic duct. There is a common bile duct and pancreatic duct. So here, the treatment is entire pancreatic head is resected, as we see here, or the pancreatic head, leaving only tiny part of the pancreas to preserve the duodenum and the vessels supplying, and then we perform what's called Roux-en-Y pancreaticojejunostomy to drain the remaining body and tail. Very important. It's essential to preserve the gastroduodenal artery and the vessels supplying the third and the fourth part of the duodenum, superior, inferior, posterior, anterior, pancreaticoduodenal, to avoid duodenal ischemia after excision of the deep lesions affecting the head. Rarely, the focal lesion in the head will extend into the duodenal wall. In such cases, a Whipple may be needed. What to do for a diffuse if the genetic and by the isotope scan diagnose diffuse congenital hyperinsulinism? Here we need to perform near total pancreatictomy, excision from the 95 to 98%, leaving only a tiny piece of the pancreatic tissue between the common bile duct and the duodenal wall. It's very challenging operation to skeletonize the common bile duct and preserve it. It's very challenging surgery. Is there a rule for laparoscopy in this type of operations? Laparoscopy particularly suitable in the congenital hyperinsulinism with the focal disease localized in the pancreatic body and the tail. However, it's very difficult to perform laparoscopy for the lesions in the head because you cannot guarantee injury of the common bile duct. The major drawbacks to the laparoscopic approach in congenital hyperinsulinism is a limited tactile feedback. As we said, you feel the focal lesion as a firmer than the surrounding structures. Here you lose the tactile feedback of non-visible focal lesion. Number two, the intraoperative ultrasound due to small ports of the laparoscopy cannot be performed adequately to evaluate the location of the pancreatic duct. Number three, dissection, resection of the pancreatic head are more technically challenging and high rate of CPD injury. There is some literature describe the use of the laparoscopic approach for head lesion, but actually there's maybe not a truly head disease rather than to be a pancreatic body or the tail. This summary is very important. The classification of the hyperinsulinism disorders in infant and children. Very essential for all pediatric surgeon and pediatrician to be very aware of this classification. The hyperinsulinism maybe appear in the immediate neonatal period and called neonatal hyperinsulinism, or maybe non-neonatal, appear later. In the neonatal, we may face with genetic causes of hyperinsulinism or acquired. Maybe acquired, yes, maybe acquired neonatal hyperinsulinism. The genetic may be isolated genetic. Isolated genetics, we speak about the congenital hyperinsulinism, diffuse form or focal form, or sometimes atypical, or called mosaic, or called line hyperinsulinism. This is the isolated, maybe syndromatic. Maybe syndromatic, yes. There is maybe other syndromes more than hyperinsulinism, like the wide spectrum category known as a Pick-Wisman syndrome and also the Turner syndrome. So this is all called genetic. So the genetic may be isolated or syndromatic. Neonatal hyperinsulinism may be acquired, yes, with maternal diabetes or especially gestational diabetes may lead to hyperinsulinism secretion, birth asphyxia, intrauterine growth retardation, perinatal stress-induced hyperinsulinism, Prenatal stress induced may lead to hyperinsulinism. Some maternal drugs. This is acquired and don't need genetic surgery. Neonatal, presenting in the immediate neonatal period. Non-neonatal, after neonates, acquired hyperinsulinism may be insulinoma, especially if the child more than 1 or 2 years. Insulinoma may be sporadic or as a part of the main one. May be surgically induced after some surgery like gastric bypass, may be drug-induced, may be autoimmune, anti-insulin, or insulin receptor activating antibodies. So very essential for all pediatric surgeon and pediatrician to put this classification for the diagnosis of cases of hyperinsulinism disorder in infant and children. The first one, neonatal or non-neonatal, genetic or acquired. Now, what's the management? The management algorithm for the congenital hyperinsulinism. Hypoglycemia, yes, severe hypoglycemia. Metabolic test, showing high insulin levels to the inappropriate to the presence of the hypoglycemia. Hyperinsulinism, metabolic results show hyperinsulinism. Then we perform diazoxide trial, positive or partial or negative. Positive or partial, continue diazoxide plus or minus octreotide feeding regimen and perform genetics searching for the others genes responsible for the congenital hyperinsulinism. Negative, no response, or as we said, diazoxide resistant. Suspect potassium ATP channel mutation or defect, perform genetic testing. If the genetic test confirmed diffuse congenital hyperinsulinism, then confirm your diagnosis again with a frozen section intraoperative and perform near total pancreatectomy. If the genetics unclear or suspected the focal lesion, then perform imaging with the isotope 18F-DOPA PET-CT to diagnose. Whether a diffuse, there is a tracer taking homogeneously all over the pancreas, then confirm the diagnosis by the frozen section and perform near total pancreatectomy. If focal congenital hyperinsulinism, confirm the diagnosis again with a frozen section and perform a local pancreatic. Essential algorithm to be fully understood by all pediatric surgeon and pediatrician how to deal with a congenital hyperinsulinism, with a severe hypoglycemia. Other causes or alternative form of hyperinsulinism. We said that there is maybe acquired neonatal, maternal diabetes, including the gestational diabetes, birth asphyxia, intrauterine growth retardation, perinatal stress-induced, maternal drugs. In this patient, the condition usually transient and resolving for most patients within several days. A subgroup of the patient with intrauterine growth retardation and prenatal asphyxia will have a prolonged condition that require diazoxide for several months prior to resolution. About 50% of the children with Pick-Weistman syndrome have what's called congenital hyperinsulinism-like condition that tend to resolve spontaneously, but 5% will require pancreatic. These 3 slides is very essential for all pediatric surgeon and pediatrician. The classification, neonatal or non-neonatal, how to manage congenital hyperinsulinism of infancy, how to manage alternative form of hyperinsulinism. Now we will speak shortly about the glycogen storage disease. It's a severe hypoglycemia due to inability of the liver to dephosphorylate the hepatic glycogen into glucose. Maybe type 1 due to mutation in inactivating mutation of the glucose 6-phosphatase enzyme. Maybe type B, inactivation mutation of the glucose 6-phosphate transporter. Hypoglycemia become apparent when the time increase between feeding and the liver fail to generate the glucose from the glycogen storage. Clinically diagnosed by the hypoglycemia and hypoinsulinemia, hepatomegaly, nephromegaly, ketosis, hyperlipidemia, unlike congenital hyperinsulinism. Survivors to the adulthood have increased the incidence of hepatic adenoma, a 10% risk of malignant transformation, and liver transplantation ultimately become necessary in these patients. What's a pancreatic tumor? This is the final issue of the presentation today. Pancreatic tumors may be endocrinal or exocrinal. Endocrinal, cold neuroendocrine tumors, NETs. The NETs may be non-functioning, not producing hormones, or may be functioning. Insulinoma, gastrinoma, viboma. Viboma is very extremely rare in children, and only reports are available in the literature. So we will concentrate on two major items, insulinoma and gastrinoma. Insulinoma from the beta cells secrete insulin, and 10% are malignant. Gastrinoma from the G cells in the pancreas that hypersecrete gastrin and lead to hypergastrinemia. The G cells normally present in the pyloric antrum but can be found in the duodenum and the pancreas, where the tumor can arise. The insulinoma diagnosed with a classic webble, hypoglycemia with the fasting, glucose level less than half of the normal when fasting, relief of symptoms with glucose. Patient typically present in their adolescence, however, younger patient may be present. Gastrinoma, on the other hand, present with syndrome, Zollinger-Ellison syndrome, gastric acid hypersecretion, severe peptic ulcer, gastrin-producing tumor. Insulinoma diagnosed with a 72-hour fast, although the positive result may be with a shorter time. When fasting, we can diagnose when the blood glucose level fell through 50 and the symptom present, blood is drawn for the plasma glucose level, the C-peptide, to ensure that this is endogenous insulin, not exogenous insulin, and also the hydroxybutyrate and sulfonylurea diagnosis. How to diagnose gastrinoma? Fasting gastrin level usually elevated, and the patient having Zollinger-Ellison syndrome should undergo secretin stimulation test, which is considered positive if the gastrin level increased. Secretin stimulation by inserting a nasogastric tube in the gastrointestinal and aspirate the fluids and then inject intravenous gastrin and show the difference. The localization for insulinoma is abdominal ultrasound CT identify more than half of the tumor, endoscopic ultrasound, MRI, intra-arterial calcium stimulation, venous sampling, and also intraoperative ultrasound help in identification. Here in gastrinoma, the identification is more challenging because the tumor often is small and maybe extrapancreatic. The CT, MRI, endothelium, octreotide scintigraphy, extrapancreatic tumors often found in the duodenal. The treatment in insulinoma, all tumors should be excised. Insulinoma usually pink and small. Malignant tumors should be excised with a free margin. Here, the gastrinoma patient initially treated with omeprazole medically. The tumor should be excised to control symptoms and prevent metastasis. Patient cured by resections should be followed closely as recurrence is common. The differential diagnosis between benign and malignant insulinoma is very difficult and can be assumed with tumor size, presence of metastasis, the hard insulinomas that cause puckering of the skin, of the surface of the pancreas appear infiltrating. Insulinomas that cause distal pancreatic duct dilatation appear to be malignant. Treatment of unresectable disease in gastrinoma include proton pump, octreotide, tumor debulking to improve the patient quality of life, chemotherapy utilized in few cases with good results. Regarding the exocrine tumors, these account for half of the pancreatic neoplasm. The pancreatic exocrine system includes the pancreatic duct and the acinar cells, maybe pancreatoblastoma, solid pseudopancreatic neoplasm, acinar cell ductal adenocarcinoma. Pancreatoblastoma, it arises from the embryonic pancreatic progenitors, diagnosed in the early childhood and more common in the boys and Asian. Prognosis relatively good with complete resection and with appropriate neoadjuvant and adjuvant chemotherapy. Relapse is also common. Solid pseudopapillary tumors, also known as a papillary cystic tumor or Frantis tumor, has a female predominance, slightly less frequent than pancreatoblastoma, can be very large mass at the diagnosis, usually present with palpable abdominal mass and abdominal pain. Usually these tumors are very slow growing, although they rarely metastasize. The excision of the regional and distant metastasis greatly improve the survival. Also, even with its inert nature, the aggressive approach with complete resection is recommended, as some patients with incomplete resection show poor long-term survival. Acinar cell cancer and ductal adenocarcinoma is less common in the pediatric. Ductal adenocarcinoma infrequently reported in children with no definitive recommendation. The acinar cell is more common. The complete resections of the both tumor types appear necessary with appropriate neoadjuvant and adjuvant chemotherapy. Finally, what's called non-neoplastic cyst of the pancreas. We may have a congenital non-neoplastic cyst or congenital cyst, usually diagnosed at an early stage and as asymptomatic mass with compression of the surrounding structures or incidentally on physical examination. The congenital cyst often found in the distal pancreas and amenable to local resection with the rim of normal pancreas. Lesion in the head should be internally drained with a Roux-en-Y cysto jejunostomy. The congenital duplications of the foregut, we already present it in a separate presentation previously, may also present at the pancreatic cyst. They have a gastric intestinal lining that maintain pancreatic ductal communication, may produce a gastric acid secretion that may cause an episode of pancreatitis. The surgical resection is necessary, enucleation, distal pancreatictomy, or pancreatic duodenoscopy. Acquired non-neoplastic cyst, called retention cyst, result from obstructions of the smaller pancreatic duct. The preoperative differential diagnosis from the other cyst or pseudocyst may be difficult, but supported by finding small cystic lesions in communication with the pancreatic duct that has a proximal structures, can be excised if symptomatic or otherwise observed. However, they often confused with the neoplastic cyst and resected and are resected for this reason. So usually resected. Thank you very much for your attention. I hope the presentation today is very important and very essential for our pediatric surgeon and pediatrician dealing with the children. It's important to know the diseases and the disorders affecting the pancreas in the neonates and the children, starting with the congenital, then the inflammatory conditions, acute pancreatitis and difference between acute pancreatitis in children and adults, chronic pancreatitis, and why. Then we go through the functional pancreatic disorders, the hyperinsulinism, catastrophe, because the brain may be lost with this high insulin production inappropriate to the presence of the glucose, and the classification, whether hyperinsulinism is the neonatal or non-neonatal. The neonatal appear immediately in the neonatal period may be genetic. The genetic may be isolated or may be combined with other syndromes. Also, the neonatal hyperinsulinism may be acquired causes. Maternal diabetes may be asphyxia, may be perinatal stress-induced, may be maternal drugs. On the other hand, non-neonatal with the insulinoma may be sporadic or part of the MEN1. Then how to diagnose and manage congenital hyperinsulinism, then how to treat other alternative forms. Then we go rapidly through the pancreatic tumors and the pancreatic cyst. I think it's an essential topic for all pediatric surgeon and pediatrician, and you should study well these items. You should understand the classification, the debates in the diagnosis, the recent management plans, the non-invasive management today for most of the acute pancreatitis, and the importance differential diagnosis of the hyperinsulinism in infancy. The role of surgery is very essential. In the acute pancreatitis, is the role? No. In the chronic pancreatitis, in the functional pancreatic disorders, in the congenital anomalies, and in the pancreatic tumors and cysts. Thank you very much for your watching, and I hope the topic is very beneficial for pediatric surgeon and pediatrician. Thank you again, and see you next subject of pediatric surgery made easy. Thank you.